joining us here this morning. My name is David Griffith. I'm the Director of Programs and Outreach for the LGBT Elder Initiative. We work with an advisory committee of individuals living with HIV to plan these programs on topics of HIV and aging. So this is the fourth in the series that we've done this year. And if you don't already get our announcements about programs, give us your phone number or email on the list up here, and we'll make sure you get the announcements about everything we have coming up in the future. I just want to talk through a couple of things that are in the folders that you all got this morning. So first, again, many of you already heard me make this reminder, but if you could fill out the demographic information form, this just helps us to collect some information for our funders, so that we can get some support to continue to do these programs in the community. There's also a lot of events coming up in June related to AIDS Education Month. So you have your AIDS Education Month flyer of all the various events that are going on throughout the month of June, along with the registration form on the back. Philadelphia Fight is the organization that coordinates the registration for AIDS Education Month activities. So there's also the website on here to sign up electronically through Philadelphia Fight. One of those events that we did want to highlight, actually two of the events we'll highlight. So Wednesday, June 7th is the HIV Prevention and Outreach Summit over at the Convention Center. We as the Elder Initiative and our advisory committee, we're going to be coordinating two workshops there that day. One of them is on healthy sexual communication and disclosure. Some of you came to the program in the fall. We did over at St. Luke's with Stephanie. She's going to be doing that similar workshop again. And we're also going to be doing something there along with AARP on Medicare and Medicaid, everything that's going on in the debates around healthcare right now, and what that means for people living with HIV. And then one other I want to highlight related to AIDS Education Month is the Reunion Project, which again some of you may have been involved with last spring. Last year it was over at William Way.
Yes.
This year we're doing it at St. Luke's on 13th Street. The Reunion Project, it's a national initiative. They put on day-long summits in different cities across the country for long-term survivors to focus on issues of how to age successfully, how to thrive as someone living with HIV. And so that is in here as well, again, through the FIGHT website, or the phone number on here is for AIDS Education Month registration. So please do register for that in advance, just so we have a head count for food, but so that should be a great program as well. Those are my announcements for now. So I'm going to bring up our first speaker, Wayne Marquardt, who is a pharmacist over at Penn. And I'll let him tell you a little bit more about what he does. And so we're going to start today just kind of talking broadly, medication safety, medication management, how to be an effective consumer of medications, and then we'll get more specific into, with our speakers later in the morning, more specific looking at treatment for HIV and for Hep C. So I will turn it over to Wayne.
Okay, thank you, Dave. For those of you who, I've spoken to this group several times before, but for those of you who don't know me, my name is Wayne Marquardt. I'm a senior pharmacist at the Hospital at the University of Pennsylvania, but I've had a long working relationship with the HIV community. I helped start the AIDS Task Force back in the early 1980s, doing the hotline a little bit, and went on to do education and training and teaching, which is what I'm still doing today. I'm not here right today to really speak directly about AIDS medications or hepatitis medications of itself, though I can certainly talk to you about that afterwards. But what my whole program is going to be on today is talking about you as a consumer and taking medications, and what are your rights about those medications, what do you need to know about them, what type of questions should you be asking about any of the medications that you're on. So to start, how many people in this room right now are not on any medications, vitamins, drugs whatsoever? Okay, well then I'm speaking to the right audience. Okay, so basically from a pharmacy standpoint, and this actually goes along with physicians as well, is about one of the things that we take a look at from a pharmacist standpoint is that there are a number of different types of medications which are out there in the way of just general classes. So you have your over-the-counter medications, your medications that you don't need to get a prescription for. You can go into a dollar store to get it. I was just ever hearing the conversation a while ago. You can go into a pharmacy, into a supermarket. You can get a lot of your medications right there. You can get your medications filled from a pharmacy, which you're going to go to from the CVS or Rite Aid, a Good Neighbor Pharmacy, any place that you're going. And now all of a sudden we're seeing a whole advent of mail order pharmacy as well, so that you're not even interacting with anybody and then you're just talking to someone over the phone and the medications are now being mailed to you. So one of the big things that we see here now is that with all these different advents of pharmacy, all of our information that we have from drugs are kind of fragmented because a lot of you are also going to different doctors. So you may have your HIV doctor, you may have your general practitioner doctor. If you're female, you may have your gynecologist, you may have a cardiologist, and whatever. So before, where we just used to go to one single doctor, the doctor knew all the medications that you're on. In the cases that we're seeing right now, healthcare is, in that aspect, is fragmented because each of the physicians is taking care of you, but they may not be sharing information of medications or diagnosis or other things along with the other physicians. So from a pharmacy standpoint, what we always recommend for our patient populations is, if at all possible, to use the same pharmacy for all your prescription and non-prescription needs, because this way that pharmacist or that pharmacy department will have an actual listing of all the medications that you're on, whether they're prescription, whether they're over-the-counter. You can also add herbal medications to that. And this is one of the other things that we can then share with other practitioners and other physicians as we're coming along. So if you're coming in and you've got different medications from 3 different doctors, and I'm finding a drug interaction or thinking that the dose is too high or something, I now can share that with the other doctors and say, well, do you know, Dr. A has your patient on this, and Dr. B is now added on this medication, and they're not going to act well together. So having a pharmacist or a physician knowing all your medications are really good. And that's one of the big things also, is not only sharing that information with myself, but if you do have multiple physicians, making sure that they have a list of all the medications that you're on as well. The other big thing that you want to take a look at is when you are taking a medication. And this is one of the things I'm going to hit upon with our elder and senior population, is the fact that many people were brought up, my partner is 85 years old, and when he was being brought up, the physician would just put you on a medication and that was it. You didn't know the reason why you were being put on it. You were just told this is what you're taking and that's it. And you were never really asked to really question it, or if you did, it was just kind of a very vague response. So one of the things that we want to take a look at now is that know what we call the indication, or what the purpose or reasoning is that you're taking that medication. And the rationale behind that is that one medication can actually have 4 or 5 different indications from it. So a simple drug, which I would call metoprolol or Lopressor, that can be used for any of your cardiovascular conditions. So it can be used for hypertension, it could be used for cardiac arrhythmias, but it can also be used as an anti-anxiety agent. We use that a lot of times for people who are coming up and doing public speaking the whole bit, to get the jitters out of the whole bit. So that one drug, if I'm not, I really need to know what it's being used for, and your physician should be as well as that. And if you're taking a number of different medications, and a lot of our elder and senior populations are at least on 4 or 5 different medications, vitamins, or different types of drugs a day, you can actually request the pharmacist, when they're putting or making the label for your drugs up, to put on the prescription label itself what it's being used for. So that if you have a caretaker who's helping you as well, they know that this is an HIV medication, this is a blood pressure medication, this is a cholesterol medication. So that may help as well. And then one of the big things I always recommend is making sure that you do keep a personal list for family or references, or in case, paramedics have to come in, whatever, and are taking you to a hospital and you're unable to speak, is that you have a listing for that. And one of the things I've brought with me, there's a number of them back here, are these medication cards. And what you can do with something like this is just put your physician, primary care physician on it, the pharmacy you're getting your medications from, and then on the inside, It's just a listing of all the medications that you have. So you can either entrust this to a caretaker. Many paramedics and actually our ENT specialists actually recommend that if they do have to go into your house for whatever reason to rescue you and you can't talk about something, is to keep this on your refrigerator, because that's usually the place that they're going to look to see if there are any medication or listings that there are there. Now, if those of you who are working also or have physicians in a healthcare system, such as Jefferson, Penn, I know Lankenau has it as well, is now a lot of this information is now online. So if you have a Penn physician, and I'm just going to speak about Penn because that's what I'm a little bit more familiar with, every one of my doctors who is in Penn has access on computer to every medication that I'm taking, every x-ray that I'm taking, and you actually have all that. You will actually, as a patient or a client, will have access to all that information as well. So that's really great, and you can actually, if your physician is not associated with one of those healthcare institutions, if you're comfortable enough with it, you can actually give them the password into your account so that they can see the medications that you're on. One of the big things also is when you're taking a look at medications is what is the timing? What is the proper time to take a medication? So do you take this before a meal, after a meal? Do you take it with a fatty meal? Do you take it on a full stomach? Do you take it on an empty stomach? You want to take a look and saying, from a pharmacist or a physician standpoint, just ask about those types of things that you want to take a look at. Also, dietary arrangements. Now, a lot of our HIV medications are actually recommended to be taken with a fatty type of meal or something fat. It's not just on a dry stomach. A lot of our medications are also taken on an empty stomach. There are certain drugs that you don't want to take them with. And then the other thing that you want to take a look at and saying, see what works best for you. If you find out that a drug that is supposed to be taken on an empty stomach is really giving you a lot of upset, you're throwing up the whole bit with it, talk to your physician or your pharmacist. You may be able to take that medication safely with some food. It may not work as well, but at least then you're getting at least the benefits of the medication. Now, from a medical equipment standpoint, and medical equipment can mean a number of different things. Is anyone here on asthma inhalers? So we've got, one of the big things is that we, from a pharmacy standpoint, I used to work in the emergency room at the University of Pennsylvania, and probably about a third to a half of the patients coming into our emergency room with asthma problems actually did not know the proper way to use an inhaler. So making sure that you know how to use that, and then since many people are on several different inhalers, making sure that which one you can use in an emergency situation when you really are having difficulty breathing, as compared to which ones are to use when you're stabilized and you're going to use those twice a day. So I had a patient a number of years ago who was in like 4 or 5 times with an asthmatic emergency, ended up actually being admitted, and I was asked to do a discharge counseling on her, and I said, bring in your medications. She brought in a bag with 40 different inhalers in it. And every time, good morning, and every time she had an emergency, she would just reach into the drawer and grab an inhaler. So she had no idea what she was taking, if it was going to be working or not the whole bit. So this is one of the things you want to take a look at. If you are asthmatic, making sure that you know which one you can use in an emergency situation and which one is not going to be used in an emergency situation. Anybody here diabetic? So we have some are diabetic also, and learning how to use your monitoring devices for that, how to take a blood sugar appropriately. One of the big things that we usually see in our population is that when patients stick themselves and they're squeezing to get that blood out, it's not the best way to get a good blood glucose sample at that point. It's not going to be very, very accurate. So we teach people how to actually use it to use these preparations to make it. And one of the great big things that we see as well, and I'm going to say this just as general from a physician standpoint and a pharmacy standpoint, we are not really good on most cases of taking time to talk to a patient about their medication. And if you kind of think about where this is at, you've taken 3 weeks to get a doctor's appointment, you've gone into the doctor's office and you've waited there 2 hours to get to see them. They see you for a few minutes and then you're just really tired, you're aggravated, you want to go home, this person is now giving you a prescription, and now you're going into a pharmacy department. And do you really want to hear me say, you need to wait a little longer so I can sit around and talk with you? So that's one of the big things that we see an awful lot of ends, but our pharmacists are trained to speak with you. So the big problem or big thing that you want to see here if you're doing that, making sure that if the pharmacist is busy at that point, or if you are tired and just say, I've caught it a day, I can't deal with any more of this now, saying, I'm going to come back tomorrow. Can we sit down and talk a little bit when we both have a little bit more time? Injectable equipment, also we're now seeing a lot of different medications which are out there which are being used inappropriately. So many of you have just recently heard about the whole controversy out there with EpiPens, for those of you who have anaphylaxis reactions and may be allergic to peanuts, may be allergic to bumblebees, may be... Excuse me? It's not only the recalled, but the problem that we've seen with a lot of this stuff is that physicians and pharmacists will give it out and they've never taught a person how to use it appropriately. And one of the big things which I've found out, which is absolutely funny, the Institute for Safe Medication Practices, which is actually right around the corner here in Huntington Valley, did a national survey with nurses. And they went up to nurses and said, okay, you're a school nurse, your patient now has a peanut allergy, here's an EpiPen, go. Nurses didn't know how to use them. And if you weren't using it correctly, instead of injecting the patient, they were actually injecting themselves. When they pressed down on, when they pressed down on the button, it was actually where the needle was coming out from. So this is one of those big things when you're looking at injectable equipment, making sure that if you are using these products, that you know how to use them before you really actually do need it. I kind of go through a trial run. Excuse me?
Do you get a reaction to that if you not have a little issue?
Well, most people are not really going to be allergic to epinephrine themselves. I mean, it can happen, but it's not. But if you're pressing down on this and you're expecting this person to get the injection, all of a sudden you've got this needle coming through and going into your thumb, it's not there. Yes, ma'am.
When I first got my EpiPen, it was 2 in there, and then they had one dummy showing you how to use it. That's how I learned how to use mine.
And
they didn't tell me how to use it.
Exactly. And this is one of the big things that we're taking a look at now. You are a consumer. You have a right to know about these things. Someone shouldn't just be giving you something and saying, look at. So what I'm up here talking about now is saying you have a number of different, what I would call actually rights, is that if we're giving you a medication, you have the right to know what's the drug being used for, how to take it, what are the side effects. We call it the 5 rights of the patients. Right patient, right drug, right dose, right administration site.
Well, my pharmacist told me how. Also told me how.
Well, let's give that pharmacist a thumbs up then.
Epinephrine, is that something like Benadryl?
It can work what we can call it antihistamine. So Benadryl can actually work in some allergic reactions, but if you have a really acute allergic reaction where your throat is tightening up and you can't breathe, you're not going to be able to swallow a Benadryl capsule, and it's not going to work fast enough. That's why they have the EpiPens for that. It's for minor allergic reactions a whole bit, and we certainly use that all the time, but epinephrine for a severe allergic reaction where you can lose your life in a few minutes for just not being able to breathe. And right now the other controversy is like how much these products are costing. So the manufacturers have kind of gone really crazy in the past couple of years. I know that one of the big things that I see in my practice is that you not always see in yours is that I know for the babies that I work with now, I'm a neonatal pharmacist, I work in a critical care, intensive care nursery. A drug which was called vitamin A, just an injection which we use to help them actually breathe, went from $100 a vial up to $1,000 a vial. Because of the fact that they can do it. And you saw the same thing with the EpiPens. The manufacturer just came up and said, okay, well, I was charging $185 a vial or a syringe, now I can go up to $500. And there's a lot of different things that are like that are going on as well. And that makes it much more difficult when you, as a consumer, just going up and hearing a prescription saying, my insurance is not going to cover this. Other big thing here, let's take a look at, even though it's not really what I would call medical equipment, is all eye drops. So for those of you who are taking eye drops or utilizing eye drops right now, one of the big things is that you're just taking this, kind of putting it in your eye. Bad idea. You're supposed to actually, what we would call, drop it in your eye. If you're taking that
tube and touching your eyes, you have an inflammation process or you have an infection going on, you're just going to keep reinfecting yourself each time you touch it. So you have to make sure that you're not touching your eye drops or your eyelids with the drops at that time. Now, medication storage is also another big issue when we're taking a look at pharmacy and pharmacy-related equipment. All drugs, all medications have an expiration date on them. And if you take a look in the package literature or the package insert, and speaking of that, if you wanted to actually see the package insert of itself, even if the pharmacist doesn't give it to you, you can go online. They are mandated by law that you can go into every medication and see what the drug company's package insert says. And those areas will actually tell you storage opportunities and saying, avoid excessive heat and light, do not go above 37 degrees centigrade, or keep this in the freezer, and the freezer should not go below this point in time. So from a pharmacy standpoint, we have very rigid guidelines on how we're storing medications. Once they get out of our hands and into the consumer, it may be a little bit different story. So usually most medications, what we're saying, should be stored at room temperature, but keeping them away from direct heat or light. So that's not keeping them on top of a refrigerator, which can get very hot. That's not keeping it in a windowsill, which can get direct sunlight on it. And then also UVA and UVB light from sunlight can actually break down medication in of itself. The other thing which we see a lot of times is that people, especially with like inhalers, for those who have heart problems and may be on nitroglycerin, they store them all around the house. They store them in the car. And if you think about this, what happens in a car yesterday? All of a sudden, we're taking a look and saying we're worried about animals in cars. We're worried about leaving children unattended in cars. One thing we don't take a look at is we need to take a look at the medications that are in there, because heat can actually destroy or inactivate a number of these medications as well. Yes, sir. Yep.
I have a question, but that's like with the inhalers too. I didn't open up my inhaler, and I don't know where I set it at, but the bag blew up. It didn't pop, but it blew up.
Because it was still in the wrapper, right?
Mm-hmm. But I couldn't use it though.
I would be concerned about that at that point. If it was exposed to that much heat that the wrapper exploded, I would be very, very careful about that as well.
How do you feel about mailers? They just drop it off at someone's front door. Do you find out, do you have issues with that?
They're not supposed to do that.
I'm not going to do that.
The whole thing with medications and being delivered, I know that I've had some personal experiences with this, is that people do leave, or UPS and whatever will leave them at the doors. Theoretically, they should be getting a signature for it. But to say on the UPS and all the other deliveries part, many times they don't know that there's medications in there.
Right. But it says on the package, you have to get a signature.
There should be, yeah. But a lot of times it's not there, and they're not taking a look at it that way. The other thing at which I've taken a look with medications is I had, we've had problems with, is that we have packages which are left on doors because someone had taken his meds from his doorstep, opened the box in kind of the alley next to my house and said, "Oh, I have no idea what this is," and threw it out. And I was like, wow. And then I had to go back and say, "Excuse me." So that's one of the big things. But a lot of places now, if you're taking a look, especially at some of these meds, I have a person that I'm very close with that has a type of cancer called multiple myeloma. And the medication that he is on, Revlimid, at cost is $12,000 a month. And what you can actually make arrangements for in these cases, and this company actually does this, is that they will deliver to your door, but they do require you to be there. They will call and say, "I'm delivering this med, you need to be there." And if you can't be there for whatever reason, they also work through like CVS Caremark, and they will actually deliver it to a pharmacy and hold it for you there until you can pick it up, because some of these drugs cannot, or pharmacies are not legally allowed to just keep them in stock. They have to come from what we call specialty pharmacy at that point.
I was able to have medication delivered to my doctor's office.
Mm-hmm. And I do see that. I don't see that as often, but I do see that actually in my women's health practices for drugs that are being used for birth control or fertility, the whole bit, because since it's going to be given in the doctor's office, they just send it right there and it's stored there with the, for the
No,
patients.
just
when
my
they come in.
everyday,
Yeah.
just my HIV prescriptions.
Now, one of the big things is that from an administration standpoint, when you're taking a look at your tablets and meds, one of the big things you want to be very, very careful of taking a look and saying, how do I swallow this? If the tablet's too big, can I cut it in half? If the capsule is a capsule, can I open it up and swallow it? Can I crush it? One of the big things you want to be very, very careful about is taking a look at these medications and just assuming that you can open a capsule up, that you can crush a tablet. One of the big things is a lot of our medications are what we call XL, extended release formulations, that will last 12 or 24 hours. If you crush it, all of a sudden it becomes immediate release and you're not going to get that longevity of it. So whenever you're looking at a capsule or something that you're not sure of, give your pharmacist or give your physician a call to see whether it is okay to crush it. Or the other big thing which I would say here as well is whether you can actually cut it in half. Most tablets, if they are what we call scored, and you see the little line in it, that is safe to cut those tablets. If there's not a line in there, they may be enteric-coated. It may be something where there's a lot of, you're going to get that med very rapidly if you just cut it or swallow it. So just kind of keep that in the back of your mind when you're taking these things. And if they are very large tablets, many times we can get tablets for you that are either smaller because in a generic version, or instead of taking a 10 milligram tablet, you might have to take 2 5 milligram tablets and they may be easier to swallow.
I have a question,
Yeah.
So I've had to split tablets from my parents before. Like sometimes they break off, that's all, and then you end up having like these little parts and
Well, how are you splitting it?
Well, I don't do it anymore, but I used to have a score, like a little thing I used to like a,
Yeah, because the tablet splitters or tablet cutters actually have what looks almost like a razor blade in it. That's safely. But I've been working in a hospital for 35 years. I've also seen nurses try to take spatulas and, you know, and knives from the area and trying to saw something in half. It's like, no. If you're going to have to do that, I would always recommend giving, you know, using a professional tablet splitter, tablet cutter if you can get it. And if you do find out that there is that you do have a little bit that's left on one end, make sure you just give that to the next day so that you're getting the whole dose within 2 days then. So if you've got a little bit of,
gotcha, okay.
you know, if you've got a little bit of particulate matter on one side, give one and then just save the other half and make sure you give everything the second day. So that patient over a 2-day period is getting the whole tablet.
So what about pills you can't split? Like I take metformin, and that's a huge pill. And also my HIV medicine is a huge pill. They get stuck in my throat. So what I do about that? Shut up.
Well, no, and that's one of the things you can talk with your physician about, because there may be the generic, if I'm not sure what meds that you're on, but there may be generic forms which are either going to be a little bit smaller, easier to do. There are preparations also that tablets, which are oblong, are easier to swallow than round tablets. And there are, excuse me?
It's a big oblong thing.
They're usually easier to, I'm just going to say they are usually easier to swallow, but drugs such as, I know that there's a very big one that we use in our HIV population for antibiotic called Bactrim, and that's a huge tablet. That's like a horse pill. So in some of these cases also there can then, if those are problems, we can actually make them up as a liquid formulation or suspension. So if you have a problem with that, let your physicians know. And well, or the other thing that you would want to do as well, when you take, this will come just a little bit later on, but when you take your meds, how much water or liquid do you swallow with it? Okay, because many people don't. One of the first things that happens is that they take a pill, and they take 2 sips of water, and then they expect it to get all the way down to the stomach with there. So, you know, a full glass of water. A full glass of water is always the best way of doing it. Well, in your case here, you know, again, this might be one of the, and we can talk about it later on, but you might be one of those where you can actually crush it. You know, if.
I've tried that.
But, you know, that's the whole.
My doctor said, she said, you can't take the whole pill.
Crush it.
That's even worse.
Well, but it's getting down into you then.
If it's crushed, you could take it with applesauce. Sprinkle it on applesauce so you don't taste
Yeah.
Now, has anybody had any side effects to their medications?
I did.
Okay, so most people are very blessed, but there are people that are going to understand that are going to have side effects. So the first way of knowing what is a side effect is reading the literature. Most every drug that you get out, someone's going to give you a handout. The unfortunate part is with the handout, many times they've gone through several layers of lawyers before you get to it. So there's all this terminology in there. But you can actually go online and talk with your physician saying, what are the drugs that I'm taking? What are the side effects that I need that you want me to worry about? What do you want me to take a look at? Am I getting dizzy? Am I getting sleepy? Am I turning pink with red spots? The big thing is that you may not know that you are having a side effect unless you're aware of it up front. So being informed, I guess the word would be, is to help you along with that. If you are not sure of those, just ask your pharmacist and ask what the side effects that you would want to worry about. Now, some of these can be physical manifestations where you are going to be able to see something, you're going to be able to feel something. Others may be a lot more benign, and you're actually going to have to come in to get some either x-rays, blood work, especially things of that sort, to make sure that the drugs are working appropriately and that you're not being overdosed or underdosed, or that they're actually working the way that they need to be at that point. But that's always going to be the great part of setting up with your physician and pharmacist what are side effects, so at least you can recognize them. Because there are other things which are maybe out there, like this friend of mine who was on the Revlimid. Even though it's working for a cancer, one of the things that it can do is cause what we call osteonecrosis in his jaw, which would be a degradation of the bone in the jaw. And unless he knew that up front, if he was having trouble swallowing or he's getting a pain here, he may never have associated that with the medication. So that's why it's one of the big things here is being let's try that again, being a consumer who is really informed about the side effects, because I think that's one of the biggest things. You know when a drug is working, but you may not know when it's not working, or if you're working with it and there are those side effects. And some of this, I'll be right with you.
Sorry, what was that drug you just said?
Oh, the Revlimid. It's called lenalidomide.
Okay.
But one of the big things here is knowing that stuff up front can actually help you a little bit later on. And many of these side effects, the physicians will say, if you're on it for a couple months, it's going to go away. You're going to be able to work through it. But there are other times when they're going to be very, very concerned and saying, stop it or come in for testing. But really one of the big things is report all your side effects to your physician or pharmacist, whether they're real or perceived, immediately. And then you have a professional who's going to be able to tell you, okay, yes, you need to worry about this, or no, I don't need to worry about it. And that's going to put your mind at ease as well. Now, as I kind of mentioned earlier, over-the-counter medications are still medications. And many over-the-counter medications can interact negatively with products that you're on that are prescription. So if you are on over-the-counter medications, make sure that your physician knows about them. And so what are some big over-the-counter medications that you guys take? Zyrtec? Okay, so that can have cardiac conditions. So if you're on blood pressure medications, you may want to be very, very careful about that. Benadryl. Okay, Benadryl actually is a good antihistamine, but it can also increase sedation and tiredness. And if you're on other medications which are going to do that, that can certainly or if it's going to lower your blood pressure to a point where you're fainting and passing out, that can work. That would be like with the Zyrtex, the whole bit. And the big thing here with both of those, which is kind of interesting, you talked about Benadryl, which can be used for allergies, which is a sedating medication. And you talked about Zyrtec, which is non-sedating. But they both have their own different side effects for the same type of thing. So with Zyrtec, you need to work about that kind of that caffeine type feel where you can get palpitations and the whole bit. And actually, if you take Zyrtec at night, since you get that stimulus, you may want to stay up all night, where you take the Benadryl at night, you're just going to sleep. But if you take the Benadryl in the morning, you may not want to be going skateboarding then.
Right, because I had asked my pharmacist today when I went to pick up my medicine, I was telling her that the doctor said I had a viral infection. I couldn't get an antibiotic for it. She said I've got to take this course, but I've had it for like 4 weeks now. So she said, am I on any kind of allergy medicine? I am, but I think that I've been on it so long that it's not even taking its course. So she told me to take a Benadryl tonight when I go to bed, see if that will subside, because it's really making me, I barely can eat.
You know, and one of the big things, I thank you for reminding me of that, one of the things I want to talk about with over-the-counter medications as well, something that you don't need a prescription for, is alcohol.
Yeah?
Alcohol will interact with a lot of these things, and if you take alcohol with Benadryl, you take alcohol with Zyrtec, there's a number of different side effects that you're going to see with this, what we call potentiate those effects. So you want to be very, very careful. Alcohol is considered a drug. We'll take a look at it from that standpoint, though it's not going to be on anybody's medication list. It's just kind of, yes, unless you're a Jehovah's Witness, most people think that you are already drinking. Okay, so one of the big things I'd heard about, because I just heard that you're talking about your nephews and the whole bit, is that medications being used for children, you can't say that that's the same dose for adults, and you can't say that the same dose for adult is going to be good for a 14, 15-year-old kid. We metabolize drugs very, very differently. We utilize them very, very differently. So if you are on medications and you do have children, making sure that especially if they're over the counter, that the weight, age, dosing is appropriate for them. Just don't assume that because they're 16 and they're strapping that they can take an adult dose of a drug. And the same thing goes on things if you're a senior, and I'll be 65 this year. But seniors and the elderly, we metabolize drugs much, much more slowly. So a drug that I could have tolerated at the age of 40 is not going to get out of my system as fast right now. So I'm either going to see some of the additional benefits, or I could also see a lot of the other side effects with them. So with seniors and our elderly population, especially if they're sick and their livers aren't as working as functionally, their kidneys are not working as functionally, they may not be able to get rid of that drug as fast from the body. So just what we mentioned before, taking all medications with water, a full glass of water out of all possible. Many meds can be taken with food and should be, because it's going to decrease the risk of upset stomach, but there are medications which are recommended not to, because food will actually interfere with the absorption of the drug. Some of our HIV medications, we need to take with high-fat meals, so you want to make sure that you've got that bacon on the side all ready to go. And and one of the big things that people take a look at also is you hear this, especially what we would call the drugs which are statins, which those are for cholesterol. And one of the big side effects that we see with a lot of our HIV medications is increase in cholesterol here. And all of a sudden, when AZT came out 20-some years ago, that was one of the first side effects that we saw, was all of a sudden cholesterols were going through the roof, and then all of a sudden grapefruit pops along and people are getting toxic and getting all these muscle spasms because of it. Grapefruit is one of those, medications will actually interact with it. It shuts down or slows down the metabolism in your liver of these drugs, and you can see some more of the toxic side effects. Now, that's only with grapefruit. We have a little bit of that with the orange juice and some of the other citrus, but grapefruit seems to be the really big offender in here. Yeah. Antibiotics in of itself is a special regimen. Whenever you're taking an antibiotic, you're not feeling well, take the entire drug as prescribed. So if you get a 10-day course, take a 10-day course. You may be feeling fine on day 2 or 3, but that bug is not completely out of your system yet. Don't save it, take it, and complete it off. The other thing is that if you do have extra medication for whatever reason, and all of a sudden the same symptoms again, that antibiotic may not work. You may have a different infection at that point, and the antibiotic will not be susceptible to that. So don't share your medications, don't save unused medications, because they may not work for it. So even though a friend of yours may say, I have the same symptoms as you, I've got runny eyes, I've got a scratchy throat, and said, oh, this worked on me, here, take this, it may not. And actually that can actually harm them, because a couple of things that you're not sure about then is that what organism that they have in them. But the other part is that where do we see a lot of our allergies coming from is antibiotics. And if you don't know if that person has allergic to allergies to that antibiotic, you can be running into a real problem there. Refrigerated antibiotics usually are only good for between 2 and 3 weeks. And then once it is, it's done. So if you've got any amoxicillin in your amoxicillin suspension in your refrigerator from last year, chuck it. Okay, now one of the big things here is I have not updated this slide, but one of the big things, which is my specialty, is pregnancy and breastfeeding. So I see a number of mothers who come in every year who are on HIV medications, who we have to worry about what happens to the drugs when they're pregnant, what happens to the children that are being born, what do we do with them. But check with your physicians, and right now for those of you, and I know that some people said that they're 60, so I don't think that you're going to get pregnant anytime soon. But it is usually safe to take your HIV. It is usually safe to take your medications during pregnancy, so but certainly check with your physician on that. Breastfeeding may be another story. You want to talk with the pediatrician about this. But one of the big things that is now coming up, the FDA just approved a whole new pregnancy clarification category last year for new drugs which are coming out. So we're no longer going with the A, B, C, D, and X combination for any drug that has been approved to become on market since 2016. We're now taking a look at all the research that goes behind it and saying this could be safe in pregnancy, but here are the side effects with it. So that's one of the things we usually see, and we've always worked with our female population on that. But now we are finding that medications that men are taking can actually affect pregnancy and can actually affect an unborn child as well. So one of the big things that we're now seeing is that with some of these drugs, and actually this lenalidomide was one of them, is that this friend of mine had to sign a waiver saying that he would not get any women pregnant, and that if he was having sex, that she would be on birth control and they would use another barrier form such as condom or whatever. So some of these drugs now are out there which actually can hurt a fetus. We had always thought in the past that it was always kind of on the women's side or the women's responsibility. We're now taking a look at this more globally, is that a drug that a man is taking can actually harm a baby as well. Immunizations, I'm not going to spend much time on, but they are important. There is no reason why anyone can't get the regular vaccines for anything, but if you are sick and you really are not feeling well, or if you're in a crisis where your T cells are really down the hole better, you may want to wait to take live vaccines at that point, because they can actually cause some problems. And finally, natural and herbal remedies. And so we do see this a lot in our Black and our African American and Hispanic population, where a lot of people do recommend herbal remedies. And I've seen a couple times where I was in a pharmacy where I wanted to actually slap the pharmacist because the drug was going to be too expensive and he didn't want to take the time to call the physician and saying, can we order something else? And I've heard people saying, well, I'm just going to go to my herbalist and get something instead. You really want to be careful when you're looking at herbs and herbal remedies and medications. Even though they're not considered drugs, they are drugs and they can act negatively with medications that you're on. The other thing that you want to take a look at here is when you are, or if you are taking a natural remedy, of making sure that you get the herb, the drug, the product from a reputable resource, not someone off the streets, and taking a look at what they are. So for example, for people who are taking ginseng for mood elevation, things along that line, over in Germany, ginseng is very regulated for that. In this country, ginseng is not regulated. So you have no idea whether you're getting it from the tuber, this natural product, or if you're getting it from the leaves and the stalks of the plant, which actually have less in it. So even though milligram per milligram, you're still getting the same weight, you may not be getting the same effect of the drug. Now, as I mentioned, yes, ma'am.
I was taking ginseng, but I think I was drinking too much of it, and it caused me to, well, I think it was actually the, what was it? Ginger? The interferon. And I was drinking ginseng while taking interferon, and it took an effect on me. It caused me to fall out, can't stand the sun, you know.
So it could.
I had all kinds of mood swings.
You could photosensitized to it, and again, depending on what product that you had, you may have gotten a good batch, you may have gotten a bad batch.
No, I thought it was the root or something.
I had the natural root.
Oh, you had a natural root.
Right, but someone told me, Bashira, a friend of ours, told us that it's good to drink, with some.
Ginseng. Ginseng tea, yeah.
Don't
Yeah,
listen to Bashir anymore.
but it was a lemon and the raw sugar that I was using inside of it, but I think I was drinking too much of it. I was
Okay.
drinking it every day, and I had an 8-ounce bottle every day, but I was drinking water with it as well. But I think what taking the interferon had some kind of effect on me because I was doing some kind of study.
I was going to say, well, I would have to check because I'm not really sure with that one, but it certainly
I
could
told
be.
the- I told
But
the-
when you stopped it, did the symptoms go away?
Yeah, I told the lady that I was doing a study with what I was drinking, and she said maybe that had an effect with the interferon. So I stopped taking it, but it still seems like I feel the same way. With
Could've been
the
interferon.
falling out, can't stay in the sun. I have to make sure I have long sleeves because it just.
Well, if you're not taking the ginseng anymore, it sounds like it would be much more from the study and the interferon itself. It wouldn't be the ginseng at that point. So I've only got about 3 minutes left, but in the back of the room there are these cards. So please avail yourselves to them. If you don't have one yourself, please take it and put all the medications. Put it on your refrigerator. If you have people that you're taking care of who are elderly, my mother has one. My grandmother has one. And big thing here is that as a consumer, you're paying for these medications. One way or the other, you're paying for them. So as a consumer, you have some rights for that. Make sure if you have any questions, don't take no for an answer. Now, it might be that someone is really busy at that point, and that's fine, but you can certainly have that person make time a little bit later on for it. Or they can also, if you take a look down, what I usually tell a lot of my patients, if we're going in for a very extended period of time, here's the information, read it. We'll come back tomorrow, write down any questions that you have so that if we're getting off on tangents, we'll go back to them. So, you've been a great audience. I want to say thank you.
My name is Pablo Tebas. I am a physician and I take care of patients living with HIV, and I direct the clinical trials unit of the University of Pennsylvania, where we do clinical trials related to HIV infection and also to other infectious diseases, not just HIV. I'm from Spain, that's why I have this funny accent. Although I have lived in the US for 23 years, but the accent never goes away. I want to make this interactive, so I'm going to focus on about aging and HIV, but there are other things that we do in the clinical trials unit. Right now, around 50% of the patients living with HIV in the US are older than 50. Half of the people living with HIV are older than 50. That's the reason for that. Because people tend to think about HIV as something that happens to very young kids. The reason for that are two things. The first one is that we have better treatments and people are living much longer with HIV. Now, if you are getting infected with HIV when you are 25, if you take your medicines and you don't have other comorbidities, your life expectancy is the same as any other 25-year-old. But you are going to have a chronic disease, you're going to have to be seeing your physician. But the medicines are better and people are living longer and healthier lives. And because of that, the HIV population is aging as we are all aging. Okay? So better medicine is one of the reasons, better treatments. And the other reason is people are getting infected at an older age. So the new infections with HIV, 15% of them are in people older than 50. That means people are having healthier lives and they are having sex when they are older than 50. And there are also little blue pills that have become very popular, and people are using them more. And then as we age, we are less worried about pregnancy, and so women say, oh, I don't need to take the pill, I don't need to use a condom because I'm not going to get pregnant. So that increases the risk of acquisition. So 50% of the people with HIV are older than 50, and these are the two reasons. A few years ago, people were talking a lot about if you have HIV, you're going to be aging faster than the general population. I don't know how much is that true. Are people with HIV aging faster? And I think what happens is patients with HIV, they tend to have a higher frequency of things that happen to people that are as we get older. But I don't think they are aging faster. It's not that suddenly a 40-year-old is going to be an 80-year-old. But things that happen to people as we age are more common in patients with HIV. Okay? Like bone disease. Go ahead.
We have more pains sooner than we would have when we like 60 or 70
Yes,
years old.
there are things that happen faster. So what I think it happens is if you look at, so let's say myocardial infarctions, MIs, heart attacks, and you look at population. So you look 40, 50, 60, 70. So myocardial infarctions go like this, go up, and in the population, as you go older, it's more likely that you're going to have an MI. If you have HIV, your risk of having a heart attack is a little bit higher than the rest of the population, and you have a line that is like this. So some people a few years ago used to say, okay, if you're HIV, this is HIV positives, and this is HIV negatives. If you're 50 years old, you look like somebody that is 70. It's not really that way. It's not really that you're aging faster, that you're still a 50-year-old man or woman, but it's not that you're aging faster. So I like when I talk with my patients, I like to demystify this thing of people are getting older faster and you're going to have a shorter lifespan because you're becoming an 80-year-old when you're 60. That's not real. What happens is you are more likely, for many reasons, to get other complications that you have to take care of. And if you do that, you're going to have a normal life. So things that happen to patients, people living with HIV, that we know it happens with more frequency in HIV positives than in HIV negatives, and we will talk about why, are bone disease. So people with HIV have more bone disease than the general population. It's not extraordinarily frequent, but it happens. Bone disease meaning thin bones, osteopenia, and osteoporosis. And in all of these things, yes?
But don't you also get the osteoporosis with old age, like for arthritis and stuff?
Absolutely. You get osteoporosis. But if you have HIV, your risk of getting osteoporosis is a little bit higher. So if 3% or 10% of the population have osteoporosis, if you have HIV and you look at the same 100 people, instead of 10%, it's going to be 15%. So it's more frequent. It's not unique to HIV patients. So that's why I don't think people are aging faster, but they have complications that are more common in people as we go old. And why is this happening? And I always do, when I talk to my students, I always draw this triangle. There are factors that are related to HIV itself. There are factors related to the medications. And there are risk factors, traditional risk factors. And so, what are traditional risk factors for bone disease? Being white, being thin, smoking are risk factors, traditional risk factors for getting osteopenia, osteoporosis, being a female, postmenopausal, all of those are traditional risk factors. Yeah. Those risk factors are more common among HIV. When you look at 100 HIV positive men or women and you compare it to 100 positive, negative HIV men or women, the HIV positives tend to smoke more than the HIV negatives. For some, not everybody, but some, they tend to be thinner. So all of those are the traditional risk factors that increases the frequency of this problem. Medications. Some of the medicines that we give to treat HIV, particularly one called tenofovir, TDF, tenofovir, makes your bone thinner. So if you are taking tenofovir plus you have the traditional risk factors, you can see how the risk becomes a little bit higher. And HIV itself, when you don't treat HIV, and many people, when they get HIV, they stay years without getting treatment until they find out that they are positive, that thins your bone. So the combination of these three things make these problems more common in patients with HIV. A little bit more common. It's not that everybody with HIV is going to have osteoporosis. It's that when you look at 100 people, they are going to have more frequently osteoporosis than if they don't have HIV infection. And it's a combination of these three things.
Right.
The other disease that is more common among patients with HIV is cardiovascular disease. So heart attacks and cardiovascular disease, cardiac ischemia, is more common in patients with HIV than patients that are HIV negative. And again, it's the same thing. You have traditional risk factors. People smoke more than the general population. You have factors that are medications. The new medications that we treat HIV now are more lipid friendly, but the old medications that we used to treat HIV with, Wayne was talking about ACT, protease inhibitors like ritonavir or darunavir, those medications increase your cholesterol. And the main risk factor for cardiovascular events in this world is the cholesterol, lipids. So because of the medications, patients tend to have higher cholesterol. And because of HIV, they tend to have a thing that we call inflammation. So inflammation predisposes you to have more cardiovascular events. Any inflammatory disease, rheumatoid arthritis you were talking about.
I got all those.
People say, for example, well, people say no. The frequency of heart attacks is not the same in the summer and in the winter. It goes up and down. And some people say in the winter is because of the flu. People get the flu, you get what we call a prothrombotic state. Your blood is more, it coagulates faster when you have an infection, inflammation, and that predisposes you to heart attacks. So it's again the combination of these three things that makes cardiovascular risk a little bit more frequent in patients living with HIV. Doesn't mean that if you have HIV and you're older than 50, you're going to have an MI. It doesn't mean that. It means that you have to pay attention to it. Your physician has to pay attention to it too and address those problems.
So I have a question. So do you order bone density tests for your patients?
Excuse me?
Is there like a bone density test that you order?
Yes, you should do a bone density test, what is called a DEXA scan, in any HIV positive patient that is older than 50. Or postmenopausal women, but it's around the same age. So when I see my patients that are older than 50, I say, happy birthday, here is your colonoscopy and here is your DEXA. People, when you are 50, you might have osteopenia, osteoporosis, you might have thin bones, but you're not going to have fractures because you start having fractures as you go older. When you become frail and you are more likely to fall is when you start having fractures. That's why it's so important to detect it early, when you are 50. Normally we do DEXAs in women older than 65 and in men older than 70, but it's better to know ahead of time, and you might consider the possibility of treating if you have osteoporosis, although the treatment, or do things like exercise, vitamin D, calcium, that will make your bone stronger. But yes, we should do DEXAs in every HIV positive patient that is older than 50.
How often should you do that?
Usually you do it every few years. You do it once and then every 5 or 3. It's not something that you have to monitor every year or anything like that. You want to make sure that you're in the normal range, and if you're in the normal range, you might repeat it in 5 years. If you are thin, if your bones are thin, then you might change that approach, but never more than every couple of years or 3 years. It's not something, it's like colonoscopies, you do them here and there, okay? We talk about bone disease, cardiovascular disease. Another thing that happens to patients living with HIV is what we call HAN, HIV-associated neurocognitive dysfunction, HIV-associated neurocognitive dysfunction. So patients with HIV, again, when you compare them to the general population, they seem to have more memory loss, activities of daily living, a little bit more difficulties than the general population. When I think about it, I have those difficulties. I forget where I park my car or wherever. And that happens to everybody to some degree. In patients with HIV, it seems to be a little bit more frequent. Okay? And we're doing research in all of these areas to try to deal with this issue. HIV associated with neurocognitive dysfunction. In the old days, in the 90s, when we didn't have good treatments for HIV, we used to see dementia. You have seen movies like The Hours, or with somebody with HIV had serious dementia. We don't see that anymore, thank God. And this is because of the better treatments. We don't see dementia, or when we see it, we can give HIV medications and people do better. But what we see now is this, I don't remember how to drive or I forget everything that I go into the street and I don't remember what I was supposed to be doing. Or that kind of thing is more frequent in patients with HIV. And again, it's a combination of these three things. And then another thing that it has become less frequent, but we still see it, is called lipodystrophy. Lipodystrophy. So patients with HIV, and this is a side effect of the medications, more than anything else. When we use old medicines like D4T or DDI, people with HIV, they tend to lose fat on their face and the arms and the legs, skinny arms, and a bigger belly. Mm-hmm. The fat in the belly is not like my fat, which is outside. It is inside the belly, and increase the cardiovascular risk. The new medications are less associated with this. So we see much less of this. But if you got it 10, 15 years ago when the medications were associated with it, it's very difficult to get rid of it. So we see it in clinics, in patients that have been under my care for a longer period of time. You still see the lipoatrophy, the thinning of the arms. Sometimes you see it in new patients, but it's rare because of the medications are better now. But it's still a problem, and it is an issue because it is stigmatizing. People say, oh, it's like, oh, you have HIV because you are.
But we should do fillers, but that's not.
You can do many things for this, but fillers work for the face. Oh, it fell? Sorry. Do I have to start from the beginning?
No, it's fine. Let me clip it onto you though, so it doesn't fall like that anymore. Alright, cool. Thank you.
So those are the things that happen more frequently in patients with HIV that in patients that don't have HIV infection. What type of research do we do at Penn? We do research in three big areas. One is prevention. And this is with people that are HIV negative. Okay? Try to prevent HIV infection. So we study vaccines. We have HIV for 30 years. We don't have a good vaccines against HIV. So we keep studying to if we can figure out a vaccine that is going to be a good vaccine. To get rid of this infection in the world, we're going to need to have a good vaccine. Is it going to happen tomorrow? No. The vaccines, we still have to learn a lot, and it's taking a long time. But we have good tools to prevent HIV. We have PrEP, which is pre-exposure prophylaxis. So people that don't have HIV, that are having risk behaviors, they can take this medicine, and that is very effective in reducing the risk of HIV. They take an HIV medication called Truvada, which is a combination of two medicines, TDF and FTC. It's called Truvada.
And if you take one pill once a day, your risk of acquiring HIV goes almost to zero. It's 95% effective. So why don't everybody use it? The problem is it's expensive. Not all insurance cover it. The people that are higher risk, they don't have insurance, so it's a little bit complicated for them to get access to this or don't know about this. And the other thing is, this prevents HIV, but it doesn't prevent any sexual transmitted disease. So if you are taking this, you still can get gonorrhea, syphilis, chlamydia, you can get HPV, herpes. So you have to, you cannot use it alone. You have to use it as a combination package to have a healthy lifestyle. Go ahead.
I have a question when it comes to Truvada and some of the many groups out there, like the ballroom groups and some of the kids from the clubs. Majority of them are using the PrEP, which is Truvada, but the stigma that goes along with it is so attached, I say. And sometimes a lot of them don't like to talk to their peers in reference to discussing their confidentialities, disclosure issues. I'm trying to figure a way where, because they call it Truvada whore, but I just think the stigma so attached should, I don't know, it's a way.
Well, I think what you're trying to say is that those kids are using that as like a party drug.
Yes.
So they're not taking it with full adherence. They're just taking it out. I'm gonna go out and party this weekend. I'm gonna take some Truvada. I'm gonna get laid. I'm gonna have unprotected sex.
Yes.
Those are the kind of people that we really want to reach and say you need to really take this. It's adherence.
Yes.
It's adherence.
Yeah, these medications, this medication only works if you take it, like any medicine. By looking at the medicine, nothing works by just looking at them. So you have to take it, and that's the main problem with Truvada. So we're looking for better ways to do PrEP. There is an injectable that you get an injection every month. It's called cabotegravir. It's an integrase inhibitor. It's a different HIV medicines. And we are doing a study that is comparing Truvada versus cabotegravir. Anybody that is HIV negative, that wants to participate, they are going to get either Truvada or cabotegravir, and it has an effect preventing HIV infection. I mean, that's the question the study is asking. Of course, and this is important, is this prevents HIV. It doesn't prevent other sexually transmitted disease. So you still have to do a lot of education and making sure that people are safe, which is part of the problem when the AIDS Healthcare Foundation director talked about Truvada horse, is that he felt that patients that were taking people that were taking Truvada, really what they wanted is to have unprotected sex, and they were not doing all the other precautions and other things. I mean, I don't think that's the approach. If this medication works, for whatever reason you want to take it, I am fine with it. I used to have some reservations, but now I don't. I mean, I see 22-year-old kids all the time getting infected with HIV, and I say, well, you should have been on Truvada, and if you were not on Truvada, because you should have been in Truvada. And for whatever reason you want to use Truvada, it's fine with me. You shouldn't get infected with HIV. That's what I don't put a judgment call in anybody. For whatever reason, it's fine.
And another question is the known barriers for those groups aged between 13 and 30. Do you know some of the commonly known barriers?
Well, most of it's like everything in the US and the health system, is many young people, many young gay people, they don't have a family support or a social structure. Many of them are uninsured. They don't have access to insurance. Many of them are unemployed, and they don't have access to insurance, or they don't know. And when you are young, you think, I don't need a doctor. I mean, come on, I am 20, I'm healthy. Why do I need to go to the doctor? And so that's, I think, the main barriers is lack of access, lack of social and family support and structure. Many people, many kids, they don't want to disclose to their parents that they are gay, or they are I want to take PrEP, then basically is, oh, my mom is going to think that I'm having sex with 20 people every night. All of those things are part of why people are not accessing. The people that need it more, prevention, are really not accessing PrEP that well. So this is an area that we are working. The other areas that we are working is how to manage all of these things that happen to people living with HIV. So how do we deal with inflammation? So that's the other big area that we're doing. And we have studies looking at cardiovascular risk. So we know that patients with HIV are having more myocardial infarct, more heart attacks than the general population. Should they be taking a statin? We know that statins decrease your cholesterol and decreases the risk of having a heart attack. So should everybody with HIV be taking a statin, even if the cholesterol is normal? So we are doing a massive study, 6,000 people, and half of them are getting a statin, and half of them are getting no statin. And we're following them for 6 years to see if this group has less heart attacks than this group. We don't know the answer. This group might end up having more toxicity because they are taking an extra medication than this group. Or they might have less heart attacks. So that's why the study is being done, 6,000. The name of that study is called Reprieve. And basically everybody that has HIV, that is living with HIV, that is not taking a statin and doesn't need a statin. If you need a statin, if you are diabetic and your cholesterol is high, you shouldn't be in this study. You should be taking a statin, okay? Like me, I have hypertension. The cardiovascular risk is a little bit higher than the general population because I have high blood pressure. I am taking a statin. I am taking Crestor now. It used to be Lipitor. But this is for people that don't need to take a statin because of the underlying disease. So we are looking at neurocognitive impairment. So the study that we're doing looking at HIV-associated neurocognitive dysfunction is the question is asking, if you use to patients that are living with HIV, if you use a medicine that gets into your brain, because we think this is mediated by HIV, if you use a medicine that gets better into your brain, like an integrase inhibitor, or will you get better? Your hand get better. So we do a lot of testing, and then we tweak the medicines that the patient is taking. We add an integrase inhibitor, and we see if the neurocognitive function gets better. That's the study that we're doing for this. We did studies about bone disease, how do you treat bone disease in patients with HIV. We did studies for lipoatrophy, switching away from D4T-DDI, those medications to different medicines to prevent lipoatrophy from happening. We do studies that are evaluating inflammation, how to deal with inflammation in patients with HIV. So that's the second big group.
So I'm thinking about this hand thing. So is that like a synapse problem, like sending a message to them?
We don't know why it's happening in patients living with HIV. We think it's the inflammation that decrease a little bit. I don't know if the synapses, but it makes the neurons working less well. And that's what we think.
Inflammation, do you mean infection?
No.
Just inflammation?
Inflammation. We know when we treat HIV, the HIV virus goes to zero. So people become what we call undetectable, no HIV virus in their system. But despite of that, when you look at markers of inflammation, they are a little bit more inflamed than the rest of the people. So if you look at sedimentation rate or C-reactive protein or interleukin-6, all of these are things that you can measure in the blood. They're still a little bit higher. They have a little bit more inflammation than the general population. It's as a group. If you get the flu, you get inflammation. So but it goes away. Okay, after you get recover, it goes away. When you get the flu, you feel tired and you feel lousy. You feel lousy because your cytokines, your interleukin-2, are very high. And then when the infection resolves, that inflammation goes away. When you have HIV, you treat HIV and your virus becomes undetectable. The inflammation goes down, but it never goes down to completely normal.
Is it particular organs that are inflamed?
Yeah, we know that some the lymph nodes are inflamed. We think because HIV destroys the immune system, kills the cells that are supposed to keep the immune system under control, and most of those cells are in the gut. The gut becomes leaky. So some of the bacteria in the gut go inside because the immune system is not in the bowel, allows the bacteria to go into the blood and produce this inflammation. It is not, as I said with the bones, it's not that everybody with HIV is having a lot of inflammation. No. It's that when you look at the population and the level of inflammation, patients that are doing well with HIV, they are a little bit more inflamed than the general population. And that little bit more inflamed might be the explanation why they have more MIs, why they have more hand, why they have a little bit more of the bone disease. It's not dramatic. The risk is what we call 1.3 or 1.4. So if your risk of having an MI is 3%, if you have HIV because of this ongoing inflammation, your risk is 3.5%. You want me to stop? Oh, 10 minutes, okay. So we are trying to deal with that and see by using anti-inflammatories things that we can decrease that risk in patients living with HIV. And this is for people that are doing well, people that are taking their Tripla or the Gemboya or whatever, Strivil, whatever the medicine they are taking, and they are doing fine. If they are interested in getting involved in research looking at this ongoing inflammation, we have trials for that, many trials. And then the third thing that we are trying to do is to find a cure for HIV. So there are 40 million people living with HIV in this world. Number of cures, how many people have been cured?
I think the PETA patient, maybe him.
One, Timothy Brown.
Yeah.
Timothy Brown was a guy who had leukemia. He was living in Germany, and he got a bone marrow transplant from somebody that doesn't have the co-receptor that HIV uses to enter the cell. So HIV, if this room is a CD4 cell, the HIV uses 2 doors. So, and you need both doors. HIV binds to the CD4 and then enters the cell with a co-receptor. So people that don't have the second door, the co-receptor, CCR5, they are resistant to HIV. They cannot get HIV. I mean, and this is not very common. It's around, in the Northern Europe, is around 3% of the population, 3%. We don't know why. Why it's more frequent there. Probably there was a virus 100,000 years ago, 200,000 years ago that selected them. If HIV had happened 500,000 years ago, all of us would be Delta 32. We will not have the co-receptor because people that had the co-receptor will have been wiped out, and this is evolution. So, but it's more common in Germany. So he got a bone marrow transplant, and then when they had to stop therapy, and the virus didn't come back. But it's only one patient, only one person. He has become a very big advocate about doing cure research related to HIV. He doesn't have HIV, but he's not doing well by any means. He has graft versus host disease. He's very frail. So this is not the solution for the 40 million people. This is only something that has made us, okay, let's try to do it in everybody and cure HIV.
Is that something like stem cell research?
Yeah, we are doing what do you mean? What do we mean by cure? There are two types of cure. One is functional, and one is what we call sterilizing. So functional means that patients living with HIV will not have to take the HIV medications, but if you look in their bodies, you still can see the HIV virus. That's a functional cure. You don't have to take your pills every day, but we have given you a vaccine or an antibody or something that keeps the HIV quiet. You're fine, healthy, you don't have complications, you don't have the inflammation, but if you look, you still can see the HIV in your body. That's a functional cure.
So can you still transmit the virus to someone?
Probably much less, because if you are undetectable, you don't transmit the virus. Okay? If you're undetectable by taking medicines, you don't transmit the HIV virus. And then sterilizing cure is like Timothy Brown. Is that you don't have to take the pills, but if we look in your body, you don't have the virus. This is much more difficult than this. So we are doing strategies to try to make people not having to take medicines every day. So we are looking at medicines that can be given every 6 months with an injection. Right. That's almost a functional cure, is that right? You go to the doctor, you get your infusion, and in 6 months later you come back, and it's almost a functional cure. We're testing vaccines. These vaccines are not for prevention, are therapeutic vaccines. So we can get a boosting of the level of your immune system, and maybe your immune system can control the virus on its own. We're doing research on that. We are modifying cells, so we are taking cells from patients, changing them with gene therapy to remove that door, and then reinfusing the patient's own cells back because those cells are resistant to HIV. It's called gene therapy. A couple of years ago, we published a big study about that. All of this is very highly investigational now. But maybe 10 years from now, this will be a way that we can control HIV in a significant part of the population that is living with HIV.
So in other words, you said, like, remember when protease inhibitors came out, David Ho, time like that at the edge, they said, well, it's infected, don't believe the hype. Just kind of like, don't believe the hype. Is that a good way to put it?
Yeah, well, I think we need to do research in cure. We still have to understand that the treatments that we are evaluating in clinical trials is still research. It's still not something that can be, and we have not cured anybody, but we're working hard to get there. That's what we want, and that's what we're trying to do. Okay? If you are interested in participating in any clinical trials, or you know somebody that might be interested, I forgot to bring cards, but you have to write this number, 215-349-8092. And just give us a call. This is the clinical trials unit. And
Clinical trials.
this is the clinical trials unit. And whatever interests you, just tell us, and we will talk with you and see if there is a study that might interest you.
Okay, you said, what's that, sterilizing?
Sterilizing cure. We are that's Timothy Brown. We are not doing bone marrow transplant in people.
Okay, now what is traditional?
The functional is antibodies or vaccines or interferon. What?
I can't understand that.
Oh, we have terrible handwriting. This is functional. Functional cure. If you are interested in this, we have a study called BEAT that is trying to boost the innate immune system with interferon. We have a study using antibodies. We will have a study looking at engineered T cells, your own T cells, called CARs. There's a lot of lingo here. But if anybody's interested, you can call and see you are always your own master in the sense that you can hear about the trials, and if you want to do it, fine. If you don't want to do it, absolutely fine too.
Is that a CAD, CAD?
Cars,
Oh, R?
like cars.
Okay.
Is chimeric antigen receptor.
Do you have to take medicine?
What?
Some of them you might, some of them you don't.
Because I ain't trying to take medicine.
And they have
You don't
to-
want to take medicines? Why?
I'm going through this interferon.
No. I mean, you went in interferon because of hepatitis C, or sorry to ask you personal questions, but
It was just
No,
a
it was
trial
for
study.
a trial that I had to take the interferon.
that was the bit. So you were in one of these trials. Interferon has side effects,
Yes.
and yeah, if you have side effects, you shouldn't participate in an interferon trial. That's fine. But there are other trials. But you are taking your HIV medicines. You are taking your HIV medicines. Yeah, sure.
You got the one they said, well, they take out the antibodies
Yes.
and fix them and put them back.
I've been reading a lot
They
of
did that
lately
already.
about hidden pools of HIV, even like organs, even though you're taking meds and you aren't detectable, but they're discovering it's down there in
Yeah,
hiding.
it's the reservoir. Yeah.
Does the Berlin patient cured of all that as well?
Yep. The reason why the Berlin patient, I mean, what happens with HIV is that when you give HIV medications, you shut down replication. But HIV integrates in the chromosomes. So it's still there in a very minute amount. Not replicating because you are taking medicines. 1 in every million cells, CD4 cells, have HIV. Okay? If you stop the medicines, the HIV virus come back. The main problem of curing HIV is that we don't know how to eliminate the reservoir, those cells that are infected. Because for the immune system, it would be nice if they look different, then you can vaccinate or do something and tell the immune system, eliminate those infected cells. But those cells look exactly, because they are not producing protein, nothing, they look exactly the same as the other million. Okay? You can do what they did with Timothy Brown, the nuclear approach, which is let's kill everything. That's a bone marrow transplant. You eliminate your immune system and you give a new immune system from somebody else. That's what they did with Timothy Brown. We cannot do that for 40 million people, and it has a ton of side effects. Timothy Brown is living with graft versus host disease, which is a complication of a bone marrow transplant. So but Timothy Brown doesn't have a reservoir. Everybody else living with HIV, they have cells that are infected with HIV. That's what we're trying to find, ways to eliminate those cells without having all the side effects.
I have another question.
Sure.
Is the
After
last
you-
question.
Okay, after you do the study, it's been roughly a year and a half now.
Mm-hmm.
Aren't they supposed to tell you something about the study?
Not necessarily.
Yes, and you're absolutely right. Sometimes we don't communicate a lot with the participants. We try to send a letter to participants when the study ends and the results are published. The bid study, the study that you participated, the bid one, it has been published.
So why have I not heard anything about it?
Because we have not done what we were supposed to do, which is send you a copy of the paper and tell you what we discovered. What we discovered in your study is that if you take interferon, the reservoir, the number of cells that are infected with HIV goes down. Not to zero, we have not cleaned it, but it goes down. Now we are doing other interferon trials to see if combining it with other things might be better.
Okay.
But you should have been told about the results of those studies. And it's our fault because in academia, we like to do the study and then we don't tell the people that participated, this is what we found. So I try to send a letter to everybody and give talks like this talk and explain the results.
And the thing about it is they took my blood, they separated my plasma from my blood,
Mm-hmm.
and they took my blood back in my body, and I haven't heard anything about it, the study. And
Call
I
Ken.
think that
You participated in Presbyterian or in the LAC Center?
Penn, University of Penn, right
Yes.
on 34th and Spruce. The City Center Boulevard. Right there in the, what's that building across the street from Children's Hospital?
Yeah.
The Perelman Center?
Yes. And
Who was your nurse? Ken?
Yeah. Why
Ken
not?
Ling. Well, you have to call him.
Yeah.
You have his number?
No, you want to find out.
3498092.
You want to
So, just wanted and I don't want to cut this off, but we do have one other person waiting to give a little presentation here. So, I just want to thank you very much for being here with us today.
I'm Dina Zarrett. I'm over at Philadelphia Fight. We have, we're an organization of community health centers. We have 4 different locations. I'm over at the John Bell Health Center. We also have, that's at 12th and Chestnut. We also have the Jonathan Lack Center, the YHEP Youth Engagement Program, and the Institute for Community Justice. There's brochures over there if you want to learn more about them. But I'm here to talk about hepatitis C. So I work in the Hep C testing and treatment program. It's called See a Difference. And we basically do everything from testing events to education events all the way through cure for treatment. We have a bunch of doctors over at the John Bell Health Center and at Jonathan Lack Center that are all infectious disease specialists, but also work in the community health setting. So yeah, that's the intro. Wait. There we go. So just some background. So your liver is the biggest organ in your body. It weighs about 3 pounds and it's located on your right side, tucked like right below your rib cage. It's actually like huge. It's about this big on you. So it's really big. The only organ bigger is your skin. And it, what does it do? It basically filters your blood. So anytime you put anything into your body, the liver is kind of what filters your blood and kind of like keeps it pure or keeps it clean. So like if you're eating a burger or you are drinking a beer or you're taking some Tylenol, all of that stuff, your liver kind of filters it through and keeps your blood as clean as possible, gets rid of the toxins in your blood basically. It also, it does a zillion different things, but that's the biggest thing. It also creates some bile, which helps you with digestion. Lots of different things, but the big one is kind of detoxifying your blood. And so here are just some quick useful terms. So hepatitis means inflammation of the liver. Hepa is liver and titus is inflammation of. So really anything that can cause inflammation of your liver is called hepatitis. So if you're drinking too much, taking too much Tylenol, any of those things can cause inflammation of your liver and can cause hepatitis. If your liver is inflamed enough, like you're drinking over the course of like 20 years, or you're taking like 5 Tylenols a day for 5 years, that kind of stuff, it can cause fibrosis, which is scarring of your liver, and then eventually cirrhosis. And cirrhosis can either be compensated or decompensated. Basically, it just means decompensated means it's not working anymore. Compensated is it's still kind of doing its job. But those are kind of just the different stages of liver disease. So that's a normal liver, and that's with cirrhosis. So cirrhosis, it's just scarred, it's bumpy, it just doesn't look good, right? It looks unhealthy, and it basically, because it's so scarred, your blood can no longer filter through it, and you can no longer like detoxify your blood or do any of the other literally hundreds of things that the liver can do. So there are a bunch of different things that can cause hepatitis. Like I said, alcohol, drugs, bacteria, but there are 3 viruses that cause hepatitis: hepatitis A, B, and C. So Hep A, there's a vaccine for. Many of you probably have it. It's only started to be regulated. Like I think in order to go to public school, you had to have it around my time. But that's transmitted through oral fecal matter. So that's like you go to a restaurant and the person who's preparing the food didn't wash their hands after going to the bathroom. That's kind of how that's transmitted. And then and that one, it's, only lasts a few weeks. It's not good, but, you're not going to have it forever. Hep B is a little bit more similar to HIV in terms of transmission. It's sexual fluids and blood is how you can get it. And that's, most people can get rid of it on their own. Some people will have it for a longer time and it becomes a more chronic infection. And there's, again, no cure for it, but there is a vaccine. So the Hep B vaccine, you get 3 different shots over the course of 6 months. And then after that, most people are immune to it forever. You got to get checked though. I didn't get immunity to it. I got to get that vaccine 6 times actually. But finally got the immunity. No, I just had the vaccine for it. So I got the shot, and now, yeah, no, I got the shot for it, so now I can't get it. So now if I got in contact with someone with Hep B, I won't be able to get it. Yeah, so now Hep A and Hep B, they're the vaccines, so you'll be immune, I'll be immune forever, or anyone who gets the vaccines. And there is actually a pretty high prevalence of Hep A and Hep B among the LGBT community. I just got that from the CDC. I don't totally know how that happened or why, but that's just on the CDC website about hepatitis, yeah?
Well, I know one way I got Hep A was from eating something spoiled. So
Yeah, from food that's gone bad.
Food they're eating isn't being.
Yeah, in oysters and shellfish that are uncooked, there's also a higher way you can get Hep A as well. So lots of different ways you can get those ones. But I'm here to talk more about Hep C. So Hep C is the most common bloodborne infection in the United States. It's estimated that about 5 million people are living with it right now. And in Philadelphia, there are about 45,000 people. It's a lot more prevalent than people really are aware of. And there's also a lot of confusion because there's Hep A and Hep B. You know, people think that they're, I even thought, I was like, oh no, I'm vaccinated against Hep C. But there's no vaccine against Hep C, just Heps A and B. And having Hep C, it's commonly called like a silent infection because you can have it for decades before you'll really start to show symptoms. But by the time you show symptoms, your liver has already progressed to that point of cirrhosis where it is pretty scarred over. So a lot of people are living with it and don't really know that they have it. It can cause cirrhosis, it can cause liver failure, in which case you would need a liver transplant, and it also can cause liver cancer. And all of those are not good. And how is it transmitted? So it's transmitted through blood-to-blood contact only. So these are the risk factors, or what we call them, for people who are at a higher risk for Hep C. So basically, any way you could have gotten in contact with someone else's blood. Before 1992, they were not screening the blood banks, so like blood transfusions. If you got one before 1992, you were in a car accident, or you got surgery, you could have put yourself at risk for exposure from Hep C. Right now, a huge way that it's being transmitted, like this week, last week, this month, is through sharing of injection drug equipment and tools. So needles, but also everything else related to the injection drug process that could get someone's blood on it and then get into your bloodstream. So that's just because of the opioid epidemic, that's a really huge one right now for people getting infected.
I have a question. So probably like in the 80s when Coke was really big, roll up dollar bills.
Yeah. So yeah, that's actually, a lot of people don't think about that, but there's actually, if you, either from snorting drugs or from smoking from a crack pipe, both are ways that you can also get Hep C, because if there's if there's blood and you bleed and it gets on the straw, or if your lips blister and blood gets on the crack pipe and you're sharing that with people, that's another one of, there's like a whole list of risk assessment questions we usually ask when we do the test, like that the public health department requires that we ask, and one of them is, have you ever shared straws, and have you ever shared a crack pipe? Yeah, so those are both ways that you can get it. Another big way nowadays is tattooing. So if your friend has a tattoo gun, and they, are having a bunch of friends over and everyone's getting tattoos, that's one way you can get Hep C. Even the ink is actually a huge thing, because people will get rid of the needles, but the Hep C virus can live in ink and moist surfaces for up to 70 days. So that's a really, really long time. So you want to save money with ink? Yeah.
Piercing parties.
Exactly, yep, and piercings, yep. So piercings and tattoos are both huge ways that people are getting it, yeah?
Would you recommend the neighborhood of Kensington, because it's so prevalent with intravenous drug users, even some of the younger population to be tested, to get tested?
Yeah, so actually, we have a huge partnership with Prevention Point, which is the needle exchange program in Kensington, and we go there at least once a week to test and draw blood for Hep C because it is, I don't want to say the wrong number, but a very, very high percentage of people who are currently using injection drugs have Hep C. So there's a huge, huge prevalence of it up in Kensington and in other places where people are actively using injection drugs. So the CDC, the Centers for Disease Control, recommends that if you have any of these risk factors, you should get tested for Hep C. If you've ever done any of this, even if it was like 30 or 40 years ago, that's how they like kind of standardize things. And then because you can catch it, it kind of resets. It has a window period of 3 to 6 months of, you got tested 6 months ago, but you might have gotten stuck with a needle since then like 6 months from that exposure is kind of how long it could take for the virus to really, the antibodies to show up in your blood. And then also, this is just kind of how the Hep C infection works. So when you first get the infection, it's called an acute infection. And 15 to 25% of people can get rid of it on their own. Like it's a flu, and they're like similar to that. Or like you're feeling really healthy that day. We don't really know why. Maybe it's something to do with their immune system. Maybe it has something to do with that, virus. But some people can get rid of it immediately. And then more people go on to have a chronic infection. And so from a chronic infection over the course of like 20 plus years is kind of how you'll see this cirrhosis and fibrosis and all that stuff we were talking about before. And actually there are a bunch of things that can kind of speed up that process. So if you have Hep C and you're drinking a lot of alcohol, if you're HIV positive, or if you have Hep B, those can all accelerate the process of liver damage. And so this is kind of just like the big chart that shows like the flow of the disease, but it really is a really long-acting virus, and so many people just don't really know that they have it. And then just because this was the HIV and Aging program, I had a little bit about HIV and Hep C. So there are really high co-infection rates. 25% of people who are HIV positive also have Hep C, and then 10% also have Hep B. But it's a really, really high co-infection rate, partially just because the modes of transmission are similar. And then, so 75% of people who are HIV positive who inject drugs are also infected with Hep C. So that was kind of that thing you were talking about. In populations where people are injecting drugs, it's a much, much higher rate of infection. And like I mentioned before, that having a co-infection will speed up that rate of liver disease and put people at an increased risk. So the CDC actually, among that list of risk factors or things that, if you have X, then you should do this. Having Hep, if you're HIV positive, you should be tested for Hep B and Hep C. And I think it says like at least once is so one time is usually good. And also vaccinated against Hep A and Hep B. So I talked about like the liver and how it does all these things for the liver, but there are actually a ton of different things that Hep C has impacted. So a lot of people, they'll get tested, they'll get treated, and then after treatment, once they're cured, they'll notice, I've had this skin problem for 30 years, and I always thought that it was a skin problem, but turns out it went away right as my Hep C was cured. And so the virus can just impact a lot of different things throughout the body, which is why so many people don't really, you would never think that, I have this eye problem and, it's actually my Hep C, or, I have this skin problem and it's actually my Hep C. So there are a lot of different things, which is just, not having any of these things is not going to be like, oh yeah, for sure, let's diagnose you with this. But it just kind of shows how many different ways the virus can impact the body. Really interesting thing, though, is how the treatment has evolved. And we're at a really exciting time in terms of Hep C treatment. So it used to be in the past, this thing called interferon. It was similar to chemotherapy in terms of its effects. It was really horrible. It only cured like 40% of people, and you had to have a intramuscular injection once a week for almost a year. So a lot of people would rather just live with the virus than even go through the treatment, especially since so many people didn't even cure afterwards. So it was a really, really horrible treatment, and we're really glad that we've moved past that, because in 2014, actually, the FDA approved this new set of drugs called DAAs, so direct-acting antivirals. And it cures up to 97% of people from Hep C. It's one pill once a day for 8 to 24 weeks. Most people it's 8 to 12, but it just depends on what kind of virus you have and how long you've had it and how far your liver disease is. So there are actually 6 different kinds of the Hep C virus. There are 6 genotypes is what they're called. And genotypes 1 through 3 are the most common in Philadelphia. The other ones are in other parts of the world more common. In Philly, genotype 1A is the most common one, but we see all genotypes 1, 2, and 3 at our clinic. And there are now 9 different kinds of medication. And these are just a few of them. And you might have seen ads for Harvoni or Epclusa or Sovaldi, Zepatier. You might have seen them on TV, and it's, there's a person staring at a tree and the roots are going through, it's very, very melodramatic. And then they're like, ask your doctor about hepatitis C. So this is what they're talking about. And so it's really great. I mean, the thing that you might have heard about it, let me see, this is the next one, is like, oh, it's $1,000 a pill. It's really expensive. And it did start out that way because it's incredible that you can cure a virus with a pill. Like, that's huge. There are no other viruses where there is a cure for with a pill. And you're done with it. So the insurance companies or the pharma companies realized this and set really high market prices for them. It has gone down significantly since then. Right now, it's usually it says the average price paid by Medicaid programs is about $20,000 for the entire course of treatment. Still really, really expensive, but at the same time, it cures you from the virus. You won't have to have a liver transplant. You won't have to have liver cancer, all this stuff.
It sounds like one of those.
Yeah.
Same genotype again and again and again.
Yeah, so that's true. People do get reinfected with Hep C. And we've actually not had a problem getting people retreated when they are reinfected. Luckily, that hasn't been a huge barrier that we've seen. But yeah, you can get reinfected with the virus. So there's always, at the end of treatment, there's always some counseling about, making sure that, if you're using drugs still or if you're getting tattooed still, make sure that you're doing it in a safe way where you won't get reinfected.
So what's your reinfection when they see for just like reinfection? If someone's been taking treatment,
Yeah.
and they got reinfected.
I don't know the exact statistics. I think at our health center, the doctors have seen a few people each that are reinfected, and it's not good because you might have resistance to that particular medication that could treat it. But because we have so many medications, they haven't found pushback from the insurance companies on getting that covered. Yeah, so I mean, this is expensive, that's $20,000, but that's not what our patients pay. Our patients maybe have a $3 copay because we're an FQHC. So
It's on the SPDP formula.
yeah, it's most people have no copay. There are some people where it's like, you need to have $3 for this, and we're like, that's so dumb. Out of the $20,000, you're gonna be a stickler about this, but that's, in the grand scheme of things, less than 100,000. But it's actually, like, as of this week, we have some really amazing, exciting news about Hep C treatment. So it's expensive, and it's expensive for the insurance companies to cover. And so they basically started out, when this medication was first introduced, with how can we treat as few people as possible? So they put up all these restrictions. So initially, there was no exception for HIV patients. Now, anyone with an HIV and Hep C co-infection can get treated and covered by Medicaid completely. So there also was a sobriety restriction. So you had to have proof that you had not had any drugs or alcohol in your system for 6 months. Some states it was 12 months, and a note from your doctor about that, which is like so discriminatory and ridiculous to say that you can't get cured of this disease because you had a drink of alcohol or because you relapsed once. So that was not good, but by 2015 we got rid of that restriction. There also was a restriction that your physician has to be a specialist in order to prescribe the medication, which in Philadelphia, not a huge problem, but if you're in middle of Pennsylvania and there's only one primary care physician in like a 50-mile radius and you have Hep C, you want that doctor to be able to prescribe you the medication if they feel comfortable doing so. And so now we're moving, that's the last barrier we're kind of moving towards getting rid of. But the big thing that we changed, or that is the big news as of this week, is that there were liver disease restrictions. So I talked about that fibrosis, that scarring of the liver. Basically, it's on a score of 0 to 4. So 0 means your liver's fine, no scarring. F4 means that you have advanced liver disease. You'll have fibrosis and cirrhosis probably. And the way that the Medicaid reimbursements worked was that you had to have an F3 or F4 in order to get treatment. So it was basically saying you have to be really sick in order to qualify for this treatment. If you were infected last week and your liver disease hasn't gotten that bad yet, no treatment, just wait until you're sicker. And so it's just a very unfair and ridiculous thing to require, is to say we can't treat you until you're sicker. And as of Tuesday, the Pennsylvania Medicaid will now, there was a big lawsuit that people, the Hep C Advocates of Philadelphia, HepCap, helped with, and a lot of people at our health center helped with, that basically is going to completely eliminate those restrictions. So as of July 1st of this year, it's going to be down to an F1. So if you have a liver disease of F1 or higher, you can qualify for treatment through Medicaid. And as of January, it'll be an F0. So, still a few months for people, but that's, a really big accomplishment that not every state has, unfortunately. And so hopefully, we're going to be able to get every single person treated. It's more an issue of, when. And now we can say July, or for some people January, but we're good about getting the July date for people. So that's really exciting and just, new news about treatments. And this is the Philly.com article. That's Tawanda. She is one of the lead linkage coordinators in our program. This was her in Harrisburg last year. This is, we're very excited about it and glad that we can, get all of our patients treated. So this is just a little bit more about the cascade of care is what it's called. And so like I was saying, how there's a lot of people that are living with Hep C that don't know about it. That's the estimate of how many people. This was a few years older. Now there's, like I said, it's about 45,000 in Philadelphia. This has it about 30,000, so it's increased a lot since then. But they only think about 47% of people know that they have the virus. So there's actually, like we were saying, that you can, 15 and 25% of people can get rid of it on their own. So the way that the test works is it's a quick finger prick, and in 20 minutes we can tell if you've ever been exposed to the virus. If you're antibody positive, that's what that tells you. So basically you had the virus in your blood and your body has produced antibodies that are trying to fight it off. Some people can get rid of it, so then the next step is to get a blood draw and see if you have an active infection. So that's that next step of HCV RNA. That's how many people have then gotten that, that blood draw and have a confirmed infection. And then all the way down there is the percent of people in medical care and the percent of people that have gotten treatment. So there's a lot of work to be done. And now that we have the cure and we can offer it to everybody, it's hopefully gonna see a lot of improvement in the next few years, next few weeks, next few months. But one reason I'm here actually is because the baby boomer population is at some of the highest risk for having had Hep C. So baby boomers, those born between 1945 and 65, are about 5 times as are more likely to have Hep C than other adults. This is straight out of the CDC. They have a recommendation now that anybody born between 1945 and 1965 should get tested at least once in their lifetime. And that is, I think that's like from 2015, I think. So it's a pretty recent thing, but that's kind of why we're here and kind of exploring more of the, trying to get more into the baby boomer and senior populations. Yeah.
I've seen that commercial in the last couple of weeks about baby boomers.
Yeah.
Were they not screening us for that all this time?
So basically the reason is that Hep C wasn't as well known, that it is transmitted through blood to blood contact until really like the late 80s or 90s. And so a lot of people, there's the blood transfusions. There are also people that might have, done drugs once in their 20s and never have since, but got infected that way. Or there's just a lot less awareness. A lot of people who have Hep C and are baby boomers have no idea how they got it. Like I barely remember what I was doing last week. Like I can't imagine like 30 years ago. Exactly, yeah, that's exactly what it was. So it's, there wasn't a lot of awareness. And there are differences within the birth cohort. So the birth cohort is 3.27% antibody positive. So it's a bit higher than overall. And within that cohort, so within the baby boomer cohort, 65% are male and 65% are non-Hispanic white. So within the people that have Hep C in that cohort, most are white males. But then if you look within like individual populations, so within the non-Hispanic black population, it's actually like 6% of baby boomers who identify as non-Hispanic black are antibody positive. So that kind of, it does disproportionately affect the Black and African American community, even though the most people, like the stereotype of a baby boomer with Hep C is going to be a white male.
Where did it come from in the baby boomer generation?
I don't know how it initially got over here and the whole like how it got big, the history behind it, but it was mostly just because there wasn't as much awareness of that this could even possibly be a thing that could make you sick. Yeah. Yeah, no, it's crazy. So you can get it from birth. So like if your mother was infected, you can be infected through just by being born. Or like as kids, there that thing where you would like become like blood sisters or whatever, blood, that kind. Or just like your friend cut their hand and you're helping them. Like you don't think about these things all the time.
Well, I think too, there's the stigma part of it is they probably thought it was just injection.
That's another huge thing, yeah. And even to this day, there's a huge stigma about it because people think, oh, I never use drugs. I don't need to get tested.
Well, like they had them say sex and anal sex too with that.
Yeah,
So,
yeah, and there is a small risk of getting it through sex, and it's
probably a higher risk than they think it is.
it's the thing is it's not through seminal fluids. It has to be through blood. So it's like blood found in seminal fluids and vaginal fluids.
Of the trauma of having sex.
Yeah, so.
Sometimes like having anal sex, and vaginal sex is really the kind of
Yeah, exactly. So anal sex, there is a higher risk because there's just more tearing, and blood. So.
But not all baby boomers get it.
No, yeah, absolutely not. It's not like you're born in 1945 and there you go, you have Hep C, So it's different. It's just that you, here, I'll show you I think this is the next slide. So this is the changing demographics of Hep C in Philadelphia. So you can see that this was in 2003, so this is like the baby boomer population. So most people who have it were in that population. And then we can see it change as time goes on. So it's not necessarily that there are more new infections, it's more these are the people who got tested and know. But then you'll start to see in this younger age group, a second group rise up. And that is from the opioid epidemic, predominantly. Also maybe a bit of tattooing, but the vast cause of that second bump is because of the increase in injection drug use and sharing.
But it has the numbers.
Mm-hmm.
they actually skip numbers, or are they saying through that time, from that time, like it says 49 to 51, then it says 53 to 55?
I think it's just the odd. I think it's just the odd numbers, so it's grouped like every 2 years or something. Yeah, yeah.
That's all I was looking at.
Yeah, no. So this is just, so it's still the most people who, like the biggest group of people that are infected with Hep C are in this baby boomer age group. But this is like the emerging population that you'll hear more about. That's where the new infections are really happening.
55 to what? 57 is that?
But that was in 2013, so like plus 4 years to that, yeah.
So if you think about what was actually happening back then, universal precautions with gloves and all the other stuff didn't start until the late 80s, early 90s.
Yeah, so a lot of occupational hazards also. People that were in the war, guys that fought in the war, have a much higher infection rate, or even just like if you're a nurse and you are caring for a patient and you get their blood on them. A few months ago, I was testing someone at a recovery center and the blood splashed and got in my eye. So, I mean, these things happen, they do. And, you know, I got my blood drawn, got tested, and I'm fine, but it's, you know, these occupational hazards are things that you would never expect or you couldn't imagine as a risk happen, yeah. The pipette, like, she was moving a lot and the pipette, like, she flicked the pipette and it splashed. It was like the tiniest amount. It just so happened that the tiny amount splashed in my eye. I was testing her for HIV and Hep C, and she was negative for both, so I didn't take PEP because of that. I went back and talked to the doctors. They said if she was HIV positive, I would have gone on PEP, but because I was literally testing her as I did this, I had that advantage. Yeah. Well, lucky, you know, still had someone's blood on my face. But so it's not the universal precaution. Probably it should be. That was exactly what my parents said when I told them was, why weren't you wearing glasses? I was like, that's a good question. I should probably do that.
For your safety, yeah.
Exactly, yeah, exactly. But so the CDC recommendations I already kind of talked about, that all individuals in this baby boomer population should be tested for Hep C. But it's not routinely screened for by primary care providers. Because you're only supposed to be tested once in your lifetime, it really hasn't been on the radar, so people like get their blood drawn once a year, and it's not included in the panel. Even like says, oh, my liver enzymes are high. Your liver enzymes can be high because you took too much Tylenol that day, or, you know, had 10 shots last night or something, you know? There are lots of different reasons for that. And so unless you really ask for it, unless your doctor tells you you got tested for Hep C and you are negative, it's hard to know. It's not really screened for. Yeah?
So how many times do you have to be tested? So say like, I got tested and I was negative. How many times, do you only supposed to get tested once?
Yeah, so in the baby boomer population, it's once. If you think you might have put yourself at risk just through an exposure or something, then you're supposed to get tested after each exposure. And there's that window period I talked about before, so it's like 3 to 6 months. So like if you stuck yourself with a dirty knife or sat on a dirty needle or whatever, you can get tested the next week, but it probably wouldn't really show up. The better thing to do would be tested in like 6 weeks and then like 3 to 6 months from then, which is when the antibodies would really, you know, be in your blood and prevalent if you actually had the disease or the virus.
So do you think, have you guys seen any comparison with the number of people infected with Hep C in the city versus the number of people in the surrounding suburbs? Because in like socioeconomic status, they might say, yo, EPA where I'm from, they're not going to test as many people because like you don't have risk factors.
Yeah.
So have they ever gone out to test and you guys get the numbers developed?
So we focus on Philadelphia. It's Philadelphia Fight. So that's so our population is that we really serve the people of Philadelphia. But the rural population has a huge problem with the opioid epidemic and all of the needle sharing and infectious injection drug use. And so there is a huge population of people with Hep C in rural areas, which is why that specialist provider requirement is not an issue in Philadelphia, but it is an issue in these rural populations because there are towns in.
Do you guys do the outreach out there?
We don't. Philadelphia Fight stays. I know, but we got we got a lot of work to do in Philly. So we're starting out there, and we're,
Don't forget about us rich black people.
No. We treat all Philadelphians, but there are programs that work more in the suburbs or in the rural counties. But there is this huge problem in the rural areas as well. Yeah, it's just, of course, harder to, we can go to a community center somewhere and, reach 50 people, whereas in farmland, there's 50 people in 50 square miles or something, which is a huge barrier to care and definitely a problem. And so this is just a little bit about how the testing session works. So I kind of already mentioned this. It's a finger prick, and then you get your result. And if it comes up reactive, that just means you have antibodies in your blood. Some people clear it on their own. And so we would do the confirmatory blood draw to double check, or non-reactive, in which case people, we kind of just say like, oh, okay, well, if these are a few areas that you talked about before where, you might be putting yourself at risk, just be aware, this, that. But that's kind of how the testing session works. It's pretty quick, and we're offering it for free today if anyone wants to get tested. Nabori is back there, and she is amazing. But also, again, you could always just ask your doctor and say, hey, like next time you draw my blood, can you add this in? Because they can just do they can just skip the quick finger prick part and just go straight to the blood draw. And this is just the last little bit about our health center. So I already talked about it a little bit, but we're a member of Philadelphia Fight Community Health Centers. We're an FQHC, and we see all patients regardless of their ability to pay or insurance status. And I think that's it. Yes. So any last questions I can answer? Yes.
I went to a Hep C class at GHMC, which because you're from Fight, I know. But that's a FQHS, is that what that is? GHMC or? Greater Health Management Corporation?
I'm not totally sure.
They're on Callowhill, 12th.
They're on Callowhill? Okay. I know there are a ton of FQHCs all throughout Philly. For us, I know John Bell's a federally qualified health center, but like ICJ, the Institute for Community Justice, is not. They don't really offer health services. We're like the floor above, so they offer free Hep C and HIV testing there, but we offer most of the health services. Jonathan Lack Center is started out as an AIDS advocacy organization and now still treats primarily HIV positive people, but they are expanding a bit. But we are the more like general primary care, plus most of our doctors are infectious disease specialists, so we do see a lot of Hep C positive patients as well as HIV positive patients.
Will you be doing mobile testing at AIDS Education Month?
Yeah, actually we will be. So for AIDS Education Month, we will be doing I know they have the van. I don't know how the Hep C program is going to play into it. I know, the focus is on AIDS and HIV, so we're going to be helping out a lot with that. We have a bunch of really great events for AIDS Education Month, like there's a prevention summit, prison summit, all that kind of stuff. Oh, you got flyers? Perfect, yeah. So that'll be good, but I don't know how much Hep C stuff we'll really be doing because we don't want to, that's not our month. So, any other questions I can answer?
Real quick, I noticed at Fight they have a class on diabetes, 4-week class. Are they going to the same with hepatitis C? Or?
So they have diabetes classes. Kim is one of the nutritionists that I know, and she's awesome. For Hep C, we're working on starting a class, either a class or support group. Through Philadelphia Fight, there are the TEACH classes, which are taught by HIV positive people for HIV positive people, and they have like ones for women, ones for people who've been incarcerated, all different groups of people, and we're trying to kind of replicate that model eventually within the Hep C community and kind of get people along all different paths of treatment and then through cure. It's obviously, now that everyone can get treated, it's going to be different hopefully in the future, because hopefully it won't be a chronic illness anymore, or it doesn't necessarily need to be. And that's not necessarily saying that every single person is ready for treatment or wants to get treated, but it's they have HIV and Hep C have many parallels between them, but also their differences. So we are trying to start that group though.